Thank you so much, Leslie. I appreciate that. Since I have 25 minutes, I'm not sure I'll be able to capture the whole evolution of the pin, but we will really talk about what we've been doing recently and what we are planning to do as the future unfolds. Like many of you, I've been coming to this meeting for the past several years. So this year's meeting is especially exciting because the theme is pediatrics. And the other thing that I'm excited about is that it seems like slowly but surely pediatric endocrinologists are increasing their presence at this meeting. I will tell you, 8 years ago when I expressed interest in making fertility the focus of my academic career, there was a lot of skepticism about that. You know, people said, we're peds endos, we don't really do anything with fertility, and that always seems strange to me because we certainly assess and manage hormone function from the gonads. So it seemed intuitive that we could potentially look at the other side of the gonad too. So this is an exciting time that I follow that passion, and I think it has worked out well so far. And a lot of that is thanks to Teresa's work. So, you know, the Oncofertility Consortium from the beginning, I think as it was imagined, was really this multidisciplinary hub to really encourage this wide exchange of ideas and push best practices forward. And within the consortium, or within Open now, there are several different subcommittees, and ours is pediatrics. So this is who I am representing today. And the mission of the Pediatric Initiative Network is really to be this international group of providers dedicated to preserving and protecting the fertility of children and adolescents at risk for infertility due to medical conditions or treatments. And you know, as we realize, kids are not just little adults, right? There's a lot of different nuances to have to think about. For one, a lot of kids have a difficult time imagining their futures. So we sit here and we talk about how important this work is because we see survivors and we see adults who express distress. But when you're sitting in front of a 14-year-old, especially one that was just told they have cancer, now they're just thinking their friends are hanging out, they're sitting in the hospital, and on the worst day of their life, we're coming in and saying, now let's talk about your future parenthood goals. That's not the easiest conversation. And it's not just the kids, there's the dynamic of the parents. So it's really navigating these complex conversations in a short period of what's really a very tumultuous time. And then finally, as Lisa did such a good job alluding to yesterday, there's a whole host of medical and legal and ethical issues that we have to think about in kids that are not the same as they are in adults. So having a group like the PIN is so critical to think about the specific issues that affect children and adolescents when it comes to this topic. So the current structure of the PIN, I work closely with my vice chair, Molly Morovic, and our past chair, Leslie Apia, who really had a big hand in building up the PIN. So we really appreciate that foundation that she has laid for us to expand. We have two major committees. One is best practices. Really, the goal is to develop strategies to optimize fertility-related care. A newer Navigators Subcommittee that I'll talk about in a minute. And then the research subcommittee to design and implement collaborative multi-site research studies to advance this care. So you can see how these committees have really come together to push this field forward. And in terms of the leadership of these committees, our best practices chair is currently Lillian Meacham with Vice Chair Holly Hofkin and the Navigators lead that we just heard from, Stacy Whiteside. On the research side, Veronica Gomez-Lobo has spent the last few years in this position with Vice Chairs Krista Childress and Maggie Dwiggins. So looking back at the past year, we've had 102 members of the PIN representing 62 institutions. It has certainly been multidisciplinary. Most frequently, we have physicians and researchers, advanced practitioners, nurses, our mental health providers, and trainees from all of these disciplines. We tend to meet quarterly as a larger group, but have these ad hoc committee and working group calls, which has really been critical, you will see, for some of these projects to move forward. So what are some of these initiatives? Well, I will tell you, one of the biggest things we talk about is what you've heard a lot about in this discussion is program development. And as far as we've come, and you know, we've heard from programs like Cincinnati and and Lurie, every year there are people who come that say, I just got recruited to this program. I'm just trying to begin. Where do I start? And a few years ago, that was one of the most common questions that was coming up, both in terms of in our in-person meetings, over the listserv, over emails, where do I start? How do I advocate for time and resources, right? It's a big difference between saying, yeah, sure, start a program, versus the institution actually investing in what's needed to make that happen. How can I identify and engage stakeholders? How do I get an IRB approved? How do I fund these efforts, right? These are big questions that people are dealing with at the front lines. So at the time, our best practices committee lead was Molly Moravec, and she led the effort to do an online survey completed by PIN members from 12 institutions, examining current practices and common barriers to fertility preservation program implementation and expansion. And what this has led to is a publication with authors that are well represented in this room that was published in Journal of Adolescent Health earlier this year. So what's nice about this is that JAH is really attracts a wide readership. So it's not just cancer, it's not just REI or urology, but this is essentially a manual to give to people to say, hey, you have a passion for this, you want to start a program, how do you do it? And not only does this provide guidance on that, but it's actually a piece of scientific literature that people can take to their institutions and say, hey, this isn't just something I dreamt up. This is, how people imagine implementing the standard of care. So this group of experts said, this is what I have to have. And that is critical for institutions, right? As much as they value our opinions, it is much more valuable to say this is actually published. And what this tells you is, what are the roles? What are those key stakeholders? What disciplines you need to go to identify a champion in each of those disciplines? How do you navigate the IRB? How do you lobby for resources? How do you develop a business plan? And the importance of a navigator, which we have heard time and time again, and those of us who have great navigators, when they go out of town for 3 days, we feel the burn, right? Or like, when are you coming back? Hope you're having fun on the beach, but, right? So just like that publication has helped, it really highlighted for us the importance of actually having a formal Navigators Subcommittee. So last fall, after the annual meeting, a group of navigators came together and said, you know what? I think we could really benefit from having our own group. So they had their first conference call on December 14th, 2018, so less than a year ago, with 7 participants. And then prior to this year's meeting, they had 25 participants from 23 institutions with international presence. And I suspect after this year's meeting, that number will have gone up even more. And so the nice thing about this group is it really provides a forum to address unique needs of the navigator group. And I think even for those of us who function as our directors at our programs, we're excited when new navigators come on to say, hey, join this group. All those questions that you have, there are seasoned people who can walk you through it, and that's so valuable. So in addition to tripling their membership, they have completed a pilot program survey that they're going to take forward. They helped arrange this legislative working lunch, and they are working on a publication for a special issue that we'll talk about in a minute. So it's really been tremendous in a very short period of time. So the next question that came up among the PIN is, what about risk assessment? So again, for people that were at the front lines, seeing these patients newly diagnosed with cancer, we were getting a lot of feedback saying that, I just want to make sure that what I'm telling these families is not arbitrary, and it's the same thing that, my partner may walk in next week and tell them, and the partner institution down the road may tell them. We need a consistent message. So really what people were saying is we need some consensus on infertility risk counseling. Now, to be careful, it's not so much saying, this institution advises OTC at this point and this other institution doesn't. It's saying, let's just speak in the same language when it comes to risk, both from a clinical standpoint and then when you're interpreting a research study, what risk categories did people use? So this was an endeavor that was thought of last year to move forward, led by Lillian Meacham. 27 PIN members were involved. Lillian says that 200 emails were exchanged. She actually counted them. 3 conference calls, 7 versions of the stratification grid. People started out by submitting what they were using, and then there was a literature search, and then a lot of emails to build consensus. So Lillian had to step out to catch her flight, but she did remind me that these titles were thought of after much debate and are no longer up for debate. But, this was, I think there were a lot of really thoughtful people involved in this process in saying that, these labels seem like it's no big deal, whether you call it low, moderate, or high, or what we came up with, but they have implications, right? So you tell someone they're at low risk for infertility, we know that that means low compared to moderate, but then 10 years later, you have someone saying, no, somebody told me I was at low risk, no worries. Like they thought that was lower than the general population. That's certainly not the message we are giving. So, it's amazing that when you use these words, they have a lot of implications. So this was the grid for the females. We had a similar grid for the males, both for chemotherapy and radiation. Lillian is working on publishing this in Journal of Adolescent and Young Adult Oncology. Assuming that goes well, we will distribute these, but we're gonna hold on to them until then. But this was a tremendous endeavor that I think is, again, gonna have a big contribution to the group and to the field. So then also last year, we spent a lot of time talking in the PIN about survivorship. So, naturally, a lot of our focus is on the time of diagnosis. That's when there is an urgent need to act, and we really need to improve access to care at that point. But what a lot of us were feeling is that, well, now you have all these survivors, and particularly when you work in pediatrics, you may have counseled someone when they were 12, or when they were 5, or when they were 15, and now they're 30, and they don't remember that. I mean, half the time they don't remember it a month later, so they certainly don't remember it 15 years later, and their priorities are different. And so it's not just fertility, but it's globally reproductive health. We need guidance for reproductive health and survivorship. So what this turned into is an endeavor to actually create a special edition in pediatric blood and cancer. This is being led by Leslie Apia and Antoinette Anazotto. There's 8 specific manuscripts that are going to be published in this journal, including pediatric reproductive tumors, male and female reproductive survivorship, late effects after BMT, fertility considerations, psychosexual function, health literacy, and reproductive care navigation. So we have moved forward really aggressively. I think all the first drafts have been completed. And this is going to be open access thanks to the generous contributions from these leads institutions and also Dr. Woodruff. So I think this, again, is going to be a really special contribution from the PIN. And then finally, in terms of looking back, one of the big things that has come up is this idea of databases. I think many of us feel, those of us who live in the US, we look at our international colleagues and collaborators, and they really seem to have figured this out. They've developed these multi-country registries, and somehow we're all sitting around trying to figure out how 2 institutions in the same city, why can't we create a combined registry? So I can't tell you that I fully understood why there is that barrier here and not in other places, but I think all of us agree that this is a very important thing to do. So this was something led by Veronica Gomez-Lobo, and the thought was just to start at least with OTC. So in 2017, a database was created at MedStar Health Research Institute. People started with entering some retrospective data, but as more and more sites came on board with opening OTC protocols, there's been a handful of sites that have been entering prospective data. And in addition to, naturally just the purpose of following these, looking at outcomes long term, one of the other benefits of this is that as things changed over in the NPC, A lot of IRBs were coming back and saying, well, what's the research part of this that you're doing, because you're not collecting any research tissue. So having this database allowed us to say, well, we're actually collecting some specific markers that is clinical research. And so that seemed to at least iron out that part of it too. So really it's been a win-win. There have been a few bumps along the road in terms of just having dedicated funding to support this, but in 2020, this database is going to relocate to Norton Children's. Maggie Dwiggins is going to take the lead on this, and she does have a research coordinator that can help support it, so I think that's very exciting. So this brings me to what happened this year. So on Monday, we were given the opportunity to actually meet from 8 a.m. to 3:30. Which was amazing. For those of you guys who were in the room, I think it was a really productive day, a lot of energy in the room. There were over 100 people there, certainly multidisciplinary, numerous institutions, again, in various phases of fertility preservation program development. Several different states were there. There was a clear international presence. And one unique thing this year is that the male group wasn't at the same time, so we actually had people like Kyle and other contributors from the male perspective, which has just been really, really helpful. And I think I told Lauren already, like, we're spoiled now. You cannot go back to giving us an hour. We will need a whole day every year to meet. Really, again, for this open forum for people to bring in their, the barriers they're facing and strategies, and allow us to get a sense of what's happening across the country. As Olivia highlighted, as we're all trying to come together to help each other, we need to know what's going on in these areas. So it was a really special, unique time for everybody to bring their ideas forward, and I think move us forward to the following year. And some of the questions, we just started out asking, certainly none of these lists are comprehensive, but we just started out saying, okay, how many institutions have a formal fertility preservation program? And we just started listing them. And then we said, how many have a dedicated navigator? So clearly that number went way down compared to the number of institutions that were in the room. Fortunately, people have been, it's been a little bit easier, it seems like, for people to network with REIs and reproductive urology. Not universally, but more so than in the past. And then we got to strategies to maximizing access. So one thing that we have used at our institution is this idea of an opt-out. So everybody newly diagnosed with cancer has an automatic referral placed to our program. And that has really helped us not miss people, right? It's behavioral economics. It's easier for people to be passive than active when they have to think about consulting you. Other programs used a hard stop in the EMR. Many other programs said, well, we're just in constant communication with the referring providers. We get patient lists, and then we look at registries in the state. We use a dedicated email address. We have these inpatient, outpatient order sets. Some people said they were trying to engage the floor nursing teams to say, sometimes the physicians forget, but the nurses can see it's the standard of care and they can order it. Education and training is certainly really important. And then just using networks within institutions of nurse practitioners that can be champions. But then we asked, how many of you wish it was a little bit better at your institution? And almost everyone raised their hands. So I think it's just a reality check of we're doing well, but there's a long way to go. And that's why having these yearly discussions and ongoing discussions in between meetings is so crucial. So then we talked a little bit about OTC and TTC, and the main things we wanted to know is who's offering it, which populations are being served. So clearly, cancer and non-oncologic conditions leading to transplant are the most common, but there are people offering it now to some patients with rheumatic conditions like lupus or renal conditions where Cytoxan is used. Some programs that have DSD-specific protocols, like here at Lurie. There was some discussion about Turner's, and then our transgender population. So we see that, as our awareness grows, we're having more and more populations where it seems like some of these fertility preservation technologies make sense. Now, you certainly don't ever want to get to the point where, yeah, you have it, let's broadly use it for everyone. There's a lot of nuances, but it was nice to hear what different programs are doing. We talked about IRB issues. we talked a lot about financial considerations. So, that's no matter what, no matter how far we come, it's always going to be, the very evident elephant in the room, as we just heard on the panel, right? So we were literally sitting there saying that, okay, if you have a bundled discounted cost, how much is that? What number did you negotiate with your institution? Because if one hospital is saying 5,000 and, one state away, they're saying 23,000, that's a big difference. And we, as, the people who are championing this, can use that to say, I can't ethically say to this patient they're gonna, have to pay 23,000 and then not tell them that this neighboring institution will give it to us for 5,000. That's really important. And then, of course, we talked about other programmatic barriers. So how do you develop a business plan? So as Kristen said, things that we never learn, like dealing with politics, well, many of us never learn to develop a business plan. I know at my institution, when I first started, I said, I want to start a fertility program. They're like, great. And I was like, great. And then I said, oh, I have no resources to do this, right? And someone said, well, you need to develop a business plan. And I'm thinking, I have no idea what that even means, right? So we need to help each other in these ways to say, okay, you did it, it worked, send me a template. I don't even know where to start, right? So that's really what this network is all about. Okay, so to move ahead on plans for our upcoming year, we typically try to identify 1 or 2 projects per committee that we feel like people want to champion and move forward. So this year, the general consensus was on the best practices side, we're going to do an AMH clinical practice survey. There were probably about 25 people in this working group who were really passionate about saying, you know what, we need to get a sense of what are people doing with AMH? When are they checking it? How are they interpreting it? How are they using it to make clinical decisions? And then on the other side, there was another working group talking about key performance indicators. And this is an area where we really are trying to learn from our international colleagues that have done some implementation on this and saying, it's really helpful to just specifically identify some of these KPIs and then start delving deeper into who's doing this and how can we, almost like a QI project. On the research side, ambitiously, we are thinking about really expanding this database idea. So OTC, TTC, and then overall fertility preservation consult databases. Different people are doing this differently at various institutions. And, one of the key things we started talking about is that, if 4 different institutions already have databases, let's at a very minimum get together and see that we're still, we're collecting the same data points, right? Because ultimately down the road, we're gonna have power in numbers. There's also some discussion about projects around tissue collection. It's important for us to continue to do the tissue research. So therefore, we need to know who's doing it and also having plans for tissue that's already stored. And then I think what's also really exciting is our psychology colleagues, James Klosky and Brooke Shervin, are really talking about delving down into the decision-making, right? So as I alluded to before, these are pediatric patients and their families. It's really important to get a handle on how people are making these decisions and are they satisfied with these decisions long-term. So I am just about out of time, so I want to leave you with a few thoughts. One is that should be very clear from this presentation that we need teams to do this work. It's great to have good ideas, it's great to have passion, but you need a lot of people, a critical mass, to move these projects forward. And I feel really fortunate to have a great group of people who have been able to champion some of these projects. My second message is that you will be met with skeptics, and sometimes those skeptics are right, but sometimes you really just have to keep following your passion. And I think all of us come together. As many people said, it's a favorite time for many of us because, the skepticism is outside and we're all in here and we're all drinking the same Kool-Aid and sharing in that experience. And so I think that's really exciting. And I did hear my colleague and friend Courtney say go blue yesterday, so I have to say go Bucks. We're having a good year so far, so hopefully that will continue. Well, you started it. I just want to wrap up. I want to thank, my PIN family, the executive committee, the PIN members, Courtney, Olivia, and Teresa for allowing us this opportunity, my family, and then my OBGYN for allowing me to come here. So